Hello and welcome. This is Dr. Alex Vasquez, and the purpose of this presentation on the integrative management of hypertension is to review the highlights of the socioeconomics, pathophysiology, and differential diagnosis of high blood pressure. This presentation was first made in January 2011, and the scope of this presentation is to review key clinical aspects of adult chronic hypertension. Future presentations in this series will detail evidence-based treatment strategies, including diet, nutrition, exercise, lifestyle, spinal manipulation, surgical techniques, and drug management. Hello and welcome. This is an audio-video excerpt of material from Integrative Medicine and Functional Medicine for Chronic Hypertension. The complete video is available at optimalhealthresearch.com. The entire functional and integrative medicine approach is detailed in the textbook Integrative Medicine and Functional Medicine for Chronic Hypertension, available from optimalhealthresearch.com, amazon.com, and other bookstores. Information sources for this presentation on the integrative management of chronic hypertension includes peer-reviewed research articles from biomedical journals, approximately 350 citations specific to hypertension from a recent review of the literature published in January of 2011. Other sources of information and perspective included in this presentation are, of course, my own training and clinical experiences as a doctor of chiropractic, doctor of naturopathic medicine, and doctor of osteopathic medicine. High blood pressure is a clinical finding that leads to the diagnosis of hypertension. This diagnosis requires 2 to 3 readings of blood pressure, systolic greater than 140 millimeters per mercury, or diastolic greater than 90 millimeters per mercury. So typically what we look for is anything above 140 over 90. If either number is above its respective cutoff, then the patient can be diagnosed with hypertension. A confirmed very high reading on one occasion is sufficient to make the diagnosis. Usually in this case we look for a systolic blood pressure greater than 160 and or a diastolic blood pressure greater than 100. Patients should be seated peacefully for 5 minutes before their blood pressure is read. The cuff must be of the proper size for the patient, and the arm should be positioned so that the cuff is at heart level. Chronic hypertension is a worldwide problem, and hypertension affects 1 of every 3 adults in the United States. Hypertension is the most common diagnosis in the practice of medicine, especially family practice. Hypertension is also the single most important risk factor for the development of cardiovascular disease endpoints, including stroke, peripheral vascular disease, congestive heart failure, and myocardial infarction. Hypertension accelerates the development of atherosclerosis, and high blood pressure can directly compromise the eyes, brain, heart, lungs, and kidneys. The diagnosis, as was reviewed on the previous slide, is straightforward, and treatment, of course, does save lives. The vast majority of patients with hypertension have no symptoms, and therefore the diagnosis requires the assessment made by the clinician in asymptomatic patients. Again, as you can see in this chart, hypertension is the most common diagnosis in the practice of family medicine, followed closely thereafter by diabetes mellitus, which will be a topic in one of our upcoming webinars. This bar graph shows the prevalence of hypertension in different societies. The second bar in this graph is U.S. whites, who have about a 25% prevalence of hypertension. Farther along in this graph, the gray bar towards the right-hand side is U.S. blacks, who have a prevalence of hypertension that's greater than 40%. So what this graph shows is that there is a racial predisposition as well as a societal predisposition, and indeed a geographic predisposition as well. But either way you look at it, and from whatever angle we look at it, certainly there's consensus around the fact that hypertension is a worldwide health problem, and that its diagnosis and treatment is a worldwide health priority. If we look at hypertension from a socioeconomic perspective, we see that hypertension is not merely a disease, it is also a business. Hypertension is the leading diagnosis in the practice of family medicine. We also see that hypertension is an industry that has direct costs approaching $200 billion per year in the United States alone. Hypertension costs more than 12% of total U.S. healthcare expenditures, more than $185 billion per year, according to figures relevant to 1998. In 1998, the direct costs of hypertension in the USA were calculated to be 12.6% of healthcare expenditures, $185 billion, and a similar figure was backed by other data. So again, hypertension is a disease, it is a diagnosis, and it's an entire industry with massive expenditures associated with it. The next few slides will discuss the differential diagnosis of hypertension, which again is the focus of this presentation. Focus of this presentation is to lay the basic clinical groundwork so that follow-up presentations can focus more on treatment and clinical management. Hypertension, as I mentioned before, is an avoidable contributor to cardiovascular disease and other forms of end organ damage, such as stroke, myocardial infarction, congestive heart failure, peripheral vascular disease, renal failure, and hypertensive retinopathy. Secondly, it's always important to consider that hypertension is always a sign of underlying dysfunction or disease. Hypertension does not cause itself, at least initially, and therefore the treatment of hypertension should focus on the identification and treatment of underlying dysfunction rather than simply suppressing the visible manifestation of this dysfunction, the elevated blood pressure. The finding of hypertension is a sign to the clinician that one or more underlying physiologic imbalances are present and in need of detection and corrective intervention. So in the differential diagnosis of hypertension in adults, we need to consider the following list at the very least: aortic coarctation, cocaine use, Cushing disease and Cushing syndrome, drug side effects, estrogen and oral contraceptives, ethanol, hypercalcemia, insulin resistance and hyperinsulinemia, licorice, overconsumption can also cause hypertension. Neurogenic hypertension, we'll talk about two different forms of neurogenic hypertension, central and peripheral. Nonsteroidal anti-inflammatory drugs, or NSAIDs, are rather notorious for exacerbating or initiating hypertension. Pheochromocytoma is a classic cause of hypertension, even though it's very rare. Gestational hypertension and preeclampsia. Primary hyperaldosteronism, also known as Conn's syndrome. Renal artery renovascular stenosis is another differential that we must consider. Renal parenchymal or parenchymal disease can cause what we refer to as nephrogenic hypertension. Sleep apnea, systemic sclerosis, thyroid disease, whether it's hyperthyroidism or hypothyroidism, tobacco use, upper cervical spine dysfunction, or what we refer to in the chiropractic field as subluxation, can also contribute to hypertension, and vitamin D deficiency can also cause hypertension. We will review for the rest of this presentation, in large part, each of these differential diagnoses in detail so that clinicians and other healthcare professionals will be able to identify when these are present or when they might be present and require the appropriate laboratory and clinical assessment. Hello and welcome. This is an audio-video excerpt of material from Integrative Medicine and Functional Medicine for Chronic Hypertension. The complete video is available at optimalhealthresearch.com. The entire functional and integrative medicine approach is detailed in the textbook Integrative Medicine and Functional Medicine for Chronic Hypertension, available from optimalhealthresearch.com, Amazon.com, and other bookstores.